Hello, my name is Kamani Dwangsavan. I am here to present this presentation regarding proper intravenous access for a computed tomography scan. In CT, some exams come with contrast, and the contrast is very viscous, so it's very important to understand what type of IV access we have for the patient in order to give the contrast to enhance the contrast to find the correct pathology that we need to see. So let's get started. Currently, the high volume of CT orders combined with limited staff and few scanners have caused delays in patient care. At the hospital that I work for, there are 3 scanners, one in the ER, the emergency department, and 2 on the main floor. The average scans are 5,000 scans per month, and that's 170 scans per day. That's a lot. And not all hospitals are like this. This is a level 1 trauma center, so that's how busy we are. And patients come in and out every few hours, or every hour there's about 3 or 4 scans. And it's a lot for the whole hospital, including the nurses, the physicians, the techs, and everyone who's involved, going from housekeeping and all that. So the lack of education and awareness among the CT technologists themselves, the nurses who take care of the patients, and the physicians who are the ones who order the scans, all need to be educated with what proper IV access is specific for which protocol, because having the improper IV can cause a delay in patient care. Because some of these scans, for instance, a CT angio or an embolism or anything like that that we need to see promptly, an IV access is something that can delay the process, and we don't want that when it's an emergent exam. So proper IV access is necessary to expedite the care for patients. Literature reports that extravasations is also among the most common complications in contrast administration. Here's a picture of an extravasation. That's contrast in the arm. When the IV is bad, that's where the contrast is concentrated in the arm. Moving forward, selecting the proper IV and its location can be challenging if it's not understood. So we want to understand this, because depending on the exam, specific IV is required due to high pressure injection rates. In order for us to obtain the things that we need to see, then having the proper one will determine if we can get the study or not. IV location definitely matters for certain studies, and we'll get into that. These are the type of CT scans that we have, the contrast studies that we talked about, and of course non-contrast where we don't need an IV, so that's easier. Infiltration. Infiltration is, again, this picture that we have here where the arm is filled with contrast and it's not going through the body. It's very painful, as you can see. If a lot of liquid is stuck in your arm or anywhere where the IV is, that's going to be painful. It gets red, heats up, and it just bubbles. It's just like someone pushing like a golf ball or something in your arm. blood contamination to patient and staff, because if it's infiltrated, taking the IV out, the catheter can have blood, and if it's an emergent thing and it just gets everywhere, then we can have blood contamination. Blood loss, multiple pokes for new IV access. No one likes to get poked, so it's just a matter of getting the right one when we know we need it. And of course, if the scan is unsuccessful and we still need it, then unfortunately, once the new IV is placed, we have to get another study, and that means more contrast, more pokes, more radiation, and that's no fun for anybody. IV fragmentation is also a thing. That means when a fragment of the catheter of the IV, it gets lodged into the veins and it goes into the person's body. And of course it causes embolization, and it can migrate to other parts of the body that we don't want to. All right. Education. Education is a solution. Like they say, there's no such thing as a stupid question. Well, education is always rewarding. So here we are learning about IVs for CT scans. So it's important that we all know the different IVs that are available. And overall, the goal of this is to have all medical staff, as I mentioned, nurses, CT technologists, physicians that are involved with the process of obtaining a diagnostic CT contrast enhanced exam, is through awareness and practice of proper IV access for the desired study. I truly believe that once a collaborative understanding from all parties is in place, then a successful scan can be obtained for our patient. So let's get to it. Different IVs are available if we can't get a peripheral IV. Peripheral meaning on the arms, hands, arms, wrists, even your foot. I've even seen some like on the chest area, on the shoulder area. Those will all work. Diffusix is a type of IV access. So a regular IV catheter is a tube on one end. So it's kind of like a straw. That's kind of like the regular IV access. The gauge, you have different gauges, and it's just like a straw. That's a regular IV access. The Diffusix on the other hand is we have this thing called injection rate. So your pressure limits, your PSI. Each gauge has a different PSI. So with the Diffusix, even if it's a smaller gauge, so for instance a 22 gauge or a 24 gauge, it's small, and normally we wouldn't be able to use a regular 22 gauge for a high flow rate. So the Diffusix, instead of it being like a straw, the Diffusix is also a tube, but within the tube, so let's say this is a straw right here, and this is the end of the catheter, that's a regular IV. But the Diffusix, it's a straw, but then it has little holes within the catheter. So it just is like there's a lot of pokes in between. So when the injection or whatever comes in, it just diffuses through the small little through the small little hose plus the end of it. So it's just a faster flowing. So it's not just a water hose, it's a water hose that has a lot of holes in that part. A Metaport, that's something that's in the chest. Central line goes straight through to the heart, in the midline is a deeper like IV, like a PICC line and stuff. IV catheter and extensions must be power rated. So if it's not power rated, meaning if there's no indication of the PSI, if there's no indication or charting of any rates to the scans, then we are not allowed to use it. By no means, not allowed. Because if you use a power injector, that is just going to go at a high rate. And we need to know that it's not going to cause any harm to the patient. Know how to chart and indicate if it's a CT compatible. Yes, charting is very important. Nurses chart all the time. And that's so everyone's on the same page. We chart, we keep up to date with what's going on with the patient, and anything we put on, what gauge needs to be charted, so that it's a way of communicating to everyone who's working for the patient, and that way the workflow can go smoothly. So this here is a Metaport, and this is a type of Metaport. And many people, so when the CT technologist asks the nurse if the Metaport is CT compatible, sometimes they say no. But if it's charted, then we would know. Or if they have an X-ray, because normally when a Metaport is placed, they have to get an X-ray to see if it's placed in the correct area. And in the X-ray, there's a little piece on the Metaport that's radio peg. You could see it. It says CT on it. So once it says CT on it, that means you're good to go. This Metaport is CT compatible. The power rating, the pressure will be able to tolerate the pressure that the contrast is moving into that tube. And so we're safe. So right here, there's a CT on the bottom, and every company does everything different. So if there's an indication there, then that's a way to know that the Metaport works. And a lot of people don't know that, because if they don't list it on the chart, then another way is, oh, go to their old imaging of their recent chest x-ray to just visually see it. Because sometimes, I mean, we all make mistakes. Sometimes we chart it incorrectly. And, you know, we try our best not to, but sometimes we do get busy, and it's understandable. But a way to completely confirm is to actually go through that image and look at it. Another solution to this is to understand and know what cannot be used for a CT. And what I mean about this is we need to know what we cannot use. As I mentioned earlier, if there's nothing telling you that there's a power rating, don't use it. There is no way we can find out. Do not use it. It's safer for the patient. Peripheral, internal jugular or external jugular. So yes, some people who are hard sticks that can't get antecubital IV access, then the neck is available, and there's two veins there, internal and external. But if it was a central line, we can, because it's going straight into it. But it was the peripheral one, no way, no how do we use it. Here in California, and I'm sure the rest of the states, we do not use it because, one, it's against the law. Our license can be taken away. And this is because of this reason. So this, again, is contrast. Just like the arm that we saw earlier, that was contrast infiltrated in the arm. Now this is contrast infiltrated in the neck. So if contrast is going in the neck It's just going in, going in, going in, going in. Sometimes, we can't be there to monitor the IV when the contrast is going because it's a time study and we have to look at the imaging outside, and we can't go check because technically we are supposed to go into the room and check the IV if there is time. So like a delayed scan of like a routine chest, abdomen, pelvis is about 70 seconds. So you have 70 seconds. You have at least a minute to check the IV. But in this case, if you're doing an angio study, there is no way to check. And once the contrast is infiltrated in the neck, this can happen, and this could obstruct the airways. So right here is the airway. This is a neck right here. This is the lungs. Air is black in X-ray. This is soft tissue. This dense part is contrast. You see how radiopaque that is? This is the clavicle. That's the bone. Bone shows up white. Soft tissue is kind of gray. And that's the airway. So this is extremely important. Never, ever, ever use the IJ or the EJ in the neck. That's just a no-no. And you can see why. All right, so we went through that. Dialysis catheter is just for dialysis. We don't use it. And we have different types of studies, as I mentioned. Angio studies, perfusion studies. Perfusion studies is brain perfusions, where we look at how the brain is obtaining the contrast, so that if we need to see any blood flow that's going in there, so how the blood is perfusing into the brain, if there's any brain activity left. So that is a type of scan that uses really high rating of contrast. Cardiac studies, triphase liver, it has an angio phase on there. There's a non-con, angio, and venous, so that's why it's called triphase. And since it has an arterial phase, then it's going to go in a high rating. And we need to know what type of IV to use. Smaller IV, larger IV, how much contrast is being diffused into that. And right arm over left arm. Yes, it makes a difference. The right arm is preferred over the left arm because of the blood flow to the heart. And it'll produce less artifacts. And this is because the left arm, when it goes through, so this is right side, this is left side. It's opposite in X-ray and CT. Right side, left side. So when the left side, when you're in the arm, the vein here, when the contrast is coming in from the IV, the contrast will come in and then it has to cross over and come back around. So that causes artifacts there. So it has the left brachiocephalic vein, it drains into the superior vena cava and then crosses over to the aortic arch. So when this comes through, it's going to be very fast, and it'll leave artifacts because it's kind of crossing around, and then finally when we need to hit our anatomy of interest or our arteries of interest, maybe the aortic arch or the pulmonary arteries, then that'll cause some type of artifacts. But if it's coming through the right arm and it comes through, it'll come straight through, and the right vein runs parallel to the ascending aorta, so it'll just dump in right there into the superior vena cava or into the vena cava, and there is less artifacts. So the right arm is preferred when we're doing an angio of the head or neck, when we're doing a cardiac study, when we're doing a PE study, pulmonary embolism. That's what PE stands for. And that is why the right arm is preferred over the left arm for a CT study. Yes, everything matters. Okay, let's move forward. Okay, drawbacks. Some problems that we have when a patient comes down with their IV is this. For some reason, there is a hub that is connected to the line of the IV, and that's not tightened. So when it's not tightened, because after it's screwed on, it's taped down. So when we check it in the CT department, we push it in, and we're doing hand injection, and even though we hand inject really fast, we can't, the contrast is going in and there's no leakage in the hub. But when the power injector for the CT machine, it's being power injected by a machine and going in at a constant rate of pressure, then it can loosen that hub and eventually come apart, and then the person starts bleeding everywhere. It's happened before. I've seen it plenty of time when we do angios of the head. So it just completely ruins the study, completely gets contrast and blood everywhere on the patient, ourselves, and all that stuff. More radiation, and it's just a simple twist of the hub, making sure it's tight and secure. Charting, as I mentioned earlier, is very important so that everyone knows what's inserted into the patient, and again, a form of communicating to one another for patient care and patient efficiency. And this is also a problem here. So when the patient is in their room or on their floor in their ward, the patient needs to be transported to CT because CT cannot be transported to the patient. So before the patient comes down, it's really good for the nurses to just flush the IV just once, just to make sure it's still working, because sometimes it's been sitting there, the patient moves, eats, walks around, and they haven't been, using it. So it could come out, and you may have given them medication in the morning, but somehow it just stopped working in the middle of the day. And once they're transported all the way to the CT department, the IV is already bad. And guess what? They need to be transported back to the room. So it's best to just check while they're in the room. If it's still working, let them go to the CT department. If it's not working, then put in a new one, and then they could come to the CT department. So there's no delay, no taking the patient back and forth, back and forth, back and forth, because the CT department for our hospital, if they're inpatients, normally the nurses have to put it in. And like I said, we have hundreds of scans a day, so there's no time to do that for us. So they actually have to go back. And then sometimes the patient comes down to the CT department with medication running, blood running, and they only have that one access, and there is no available IV for the contrast. So the CT technologist is not allowed and not licensed to pause the medication. They're not allowed to unhook the medication because we don't know what the medication is for, and that could be harmful to the patient. So it's best if the IV is tightened, it's tested before they come, and also available and nothing connected to it. And patients do get transferred to different hospitals with the IV. Some come from the prison, some come from other hospitals, and we all use different types of IV from different companies. So if it doesn't indicate it on there and we don't know, then we have to put a new one. Unfortunately, they do have to get poked again if we cannot tell, and indicate what pressure that IV is. We want to have this implemented all around the hospital, and that will include all staff members so that we are all educated on the need of proper IV route. This will result in a more effective workflow, more efficiency. It'll decrease harm to both staff and patients and decrease delay in patient care if this is all implemented. The equipments that we use, as I mentioned, we use a power injector, and the high ratings we use about 300 psi for routine studies, 350 psi, and that's for higher rates. We do go in at 5 milliliters per second. So imagine pushing 5 milliliters per second into an IV. Everything that we use there, everyone that's involved on all floors, emergency department, even outpatients, the patients that just come in for routine studies, all of the CT department, because that's our job to get the correct study. And support and outside service, IV start nurses, that's their job. Their job is to get access on a patient, IV access on a patient that's difficult, because some people are drug users, some people, they just don't have veins, whatever it is, some type of medication they are. If one arm is not capable of having it because that's their dialysis arm or whatnot. I've seen IVs on the thumb, on the toe, in between the toes, and it's pretty insane where we can get lines from. So if there's a will, there's a way, and ultimately if there is no peripheral one, as I mentioned earlier, there is the central line. And we do have ultrasound guided IVs that sometimes work and sometimes they don't work. They go in deeper and it's more visualized, but I've had ultrasound guided IVs not work before, multiple times, because of just location and the pressure that we use. So it's important. Let's see what's next. I believe that performance is expected to increase as a result of explaining and understanding the importance of a proper IV access for a patient and the study that they need to have. Education, awareness, charting. This will all increase performance and safety to the patient. We'll be more efficient because we decrease all these delays. The time explaining what a proper IV access needs to be each time to each nurse, to each doctor. Because sometimes a doctor or physician will come to the CT department and wonder what's taking so long, why haven't we scanned the patient yet? And this is because there's a delay in IV. There may be a 22 gauge IV access, but we are not able to use a 22. We need a bigger gauge. So that will cause delays, and some doctors, they're not aware of that. They see that the patient has an IV, but just because the patient does have an IV doesn't mean that we can use it. So that's why it's important for all parties, physicians, nurses, technologists, to understand that. And if we have to keep explaining that to everyone, then that's a delay in patient care. And as I mentioned earlier, this will decrease harm to the patient, harm to ourselves, harm to everyone working on there. less pokes to the patient, less radiation exposure, and we don't want any infiltration because that's no fun. That could be really bad for someone, especially if they're an older patient and their skin's very fragile and there's infiltration, then it's so much more painful for them. And speaking of elderly, imagine having to go back and forth from the room to the scanner, from the room to the scanner, because there's an infiltration or a bad IV or the wrong IV when they show up to the room or not. Or when we have a broken bone and you have to be moved so many times. It's no fun. We don't want that. Our priority is our patient. Currently, this is what's going on in the hospital. We're having delays in obtaining an intravenous access to get the study completed and to get the patient the care that they need, because the hospital relies so much on imaging to see what's going on internally, and it's a way to diagnose and see what's going on. And when there is no IV available, then it makes it difficult. And of course, it's not the easiest thing to get because IVs are inside of us and not everyone's veins is prominent enough to get the access. And once it's in, charting is so important. And that's why we have our system to share the information. And we don't live in a perfect world. Things happen, and we just do the best we can to get the patient in and out the more effective and efficient way without harming the patient anymore. And here is another reason of how we can harm the patient more than we need to. So infiltration, extravasations, it happens, and sometimes it's a good IV, but their veins cannot tolerate it. I've seen a lady get poked 20 times, at least 20 times, not exact, I wasn't counting, but at least 20 times all over. And this was because the nurse was just using her arms, both arms. She wasn't going anywhere else but her arms. And it's kind of scary when they don't know that they can go anywhere else. Another thing to really consider is when we are doing, let's say this arm right here is an arm that got, kind of amputated or got shot. Someone shot this patient's arm. Let's just assume someone shot this patient's arm. And the patient comes in, they got shot down here, or let's say they got shot up here, right? They got shot up here. There's a bullet in there, or there may or may not be a bullet in there, but it entered the patient's body. And now we need to get a CTA of their upper extremity. So the patient comes with the IV on the same arm. Can we use it or can we not use it? That is the question. And the answer is no. No, can we do that? Because if the IV axis is right here and the bullet's up here, what if the contrast goes in and there is no blood flow and the bullet actually went through one of the arteries? So the contrast will go in and the contrast will not go anywhere because the bullet is went there. And then of course there will be contamination and all that stuff of contrast flow. So it's just not the right thing to do. Never put an IV on the same place that you need your the anatomy of interest. Never. So if you're concerned about the right arm, the IV needs to be in the left arm, and vice versa. If you're concerned about the left arm, the IV needs to be on the right arm. So that's a dilemma in itself. Another thing to really consider is, let's say this patient came, IV infiltrated up here, but now the nurse put a new IV in the hand because they found a new IV. They weren't able to get a new one on the AC. You can't use the other arm. And then so the nurse put an IV on the hand. Is that acceptable or is that not acceptable? Let's think it over. IV in the hand. Infiltration in the upper arm. Contrast going through. Boom. It hits that contrast where that I can't say it, where it's infiltrated. So yeah, there's a dead end. And that means the answer is no. No, 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 no. When there's an extravasation, I got that word that time. When there's an extravasation, never put an IV below that extravasation. There's no free-flowing blood contrast that's going to go through. So when there's an extravasation there, or there, or there, or there, you go higher. You put in an IV higher than that. So never go under the extravasation, always go over the extravasation. And that goes for any infiltrations. It just makes sense, right? Because you want, if there's a crash here, and this is the highway, this is the freeway, and you want to get through to your destination, let's say the heart, you want to get through to your destination, and there's traffic, you're not going to go through where there's a car accident. You want to go away from the car accident because you can't get through. There's just going to be another collision and just going to be backup. So don't go through traffic. Don't go through an accident. Take the other route. Okay? Okay. I think that kind of wraps that up, and I hope there's a better understanding about the contrast, the IV access, who needs to know, where it needs to be, the location, and everything that we need to have. And that should wrap up this little session of proper IV access for our patients and how we can be more efficient, effective, and work together to get the patient scan completed. And always remember to be cautious around the radiation room. So hopefully this was helpful. You got some information out of it, and you'll spread the word and let other people know what you've learned today. And if I did say something that needs to be corrected, I am more than happy to hear about it, and we can talk about it, and I can maybe learn something from you. So please take this and embrace it and share and educate, and let's make this world a better, loving, safe, healthy place. And that's all I have for you, so toodles.